So, we're live. Good evening, everyone. This is Ankana, the assigned moderator from IGCP Group. I welcome all the delegates across the country in today's webinar. We are fortunate enough to get supported by the doctors. Thank you, all the doctors, for taking out time to join us today. Today, we are going to cover the topic that is clot, inflammation, and kidneys. The APS, lupus nephritis overlap challenge will shed light on recognizing these overlap early, differentiating mediated injury from thrombotic damage, and tailoring treatment strategies that balance anticoagulation with immunosuppression. Hence, without any further delay, I'm taking this opportunity to welcome today's master doctor, our very well-known Dr. Sunil Prakash, sir. Sir is the director and head of nephrology and renal transplant services at BLK Super Speciality Hospital, Delhi. Now, I would like to hand over the session to you, sir. Kindly proceed with the discussion. Over to you.
Thank you, Ankana. It's a pleasure to be part of AGCP, one of the biggest and pioneers of the group in the country. So I will take you through this very interesting patient who came next, who came to us and just before I get going, I have a few words that SLE is a prototypic autoimmune disorder and it can involve many organs. Kidney is its favorite, and lupus nephritis, that is involvement of the kidney, occurs in 60% of all SLEs, and it is also a determinant of the prognosis of the disease. So what we are saying is, if somebody has lupus nephritis, the prognosis of that SLE patient is far worse than the one who doesn't have it. Sometimes it is also associated with antiphospholipid syndrome, and this confers a very high risk for thrombosis, neurovascular complications, abortions, etc. So, neurological sequelae such as press further complicate the issues. Next, and we have to take all these things into the conundrum. Next, please. So this vexatious triad in this patient, as we well know that immune-mediated injury we expected, but then this patient had mechanical obstruction in the form of urolithiasis, which was causing hydronephrosis and was an important contributor to the renal failure caused by lupus. And this case exemplifies a convergence of SLE, antiphospholipid syndrome, PRES, and obstructive nephropathy. So basically, I am presenting this case to tell you, friends, that sometimes we have to be very vigilant and multidisciplinary involvement is required to optimize the outcomes. Next. A few slides about the patient. So this was a 43-year-old woman who did not have any prior known comorbidities except that she had a history of infertility. There was no significant family history next of autoimmune diseases, hypertension, diabetes, etc. Next, please. She complained of generalized weakness for 2 months, shortness of breath for about 3 weeks, and slurred speech for 2 days. The onset was insidious, but the course was progressive. Next. She had 140/90 blood pressure on admission, heart rate was 92. She did not have fever, she was pale, and there was some slurring in her speech, but there was no other positive finding. There was no history of rash, arthritis, serositis, dyspnea, etc. on presentation. Next. Prior past history, 2 weeks earlier, the patient had severe anemia and her platelets were also very low. It was found that she had moderate renal failure, creatinine of 5.1. The doctor there treated her with 3 units of blood, which increased the hemoglobin to 8 from 4, but the creatinine also increased a little bit. But the patient was discharged without any definitive diagnosis or advised. One day before admission to my facility, the patient again developed severe anemia, thrombocytopenia, and creatinine really jumped up. She went into advanced azotemia, and at that time, we found that she had pancytopenia, but WBC was raised. Creatinine was very high. She had advanced azotemia with severe metabolic acidosis. And I'm only presenting you the positive findings. We did plethora of tests. In autoimmune workup, the ANA was strongly positive, Hep 1 by 12, 100 positive. Complements were getting consumed, C3 was low, ANT, UABNP was equivocal. Other tests, direct Combs was positive, D dimers were elevated, and DRVVT was positive, and phospholipid antibodies was positive. Adams 13 activity was reduced to 38%. The peripheral smear did not show significant schistocytosis. They were 0.5%. Next, please. Yeah. As the patient had slurring and was slightly encephalopathic, we did a CT. It showed hyperdense occipital lesion. You can see here very clearly. And in the MR of the brain, there were hyperintensities in bilateral parieto-occipital regions, suggestive of posterior reversible encephalopathy. Next, please. And the ultrasound shows hydronephrosis with multiple renal calculi. You can see the calculi here. In the NCCT, she had multiple renal calculi, they were clearly visible, and there was some cortical thinning here. You can see some scars and thinning. Next, please. Patient had some hydronephrosis also. So this patient had SLE as virtued by ANA positivity and other tests. With APLA, DRVVT was present, and she came as autoimmune hemolytic anemia. She was having low hemoglobin again and again, in spite of transfusion, refractory thrombocytopenia, and there was evidence of thrombotic microangiopathy. Posterior reversible encephalopathy syndrome was present, and acute kidney injury was possibly being also contributed by bilateral renal calculi, which was causing obstructive nephropathy, along with the other perturbations brought in by SLE. Next, please. She was admitted in ICU, and hemodialysis was initiated after putting a right DJ stent. You see, dialysis was started, and once she was stabilized, the urologist put a right double J stent to cause decompression of hydronephrosis. And once the patient stabilized, we gave her pulse methylprednisolone for 3 days, followed by oral prednisolone. We also needed to give a lot of platelets, and 5 sessions of plasmapheresis were done, along with rituximab, 2 doses apart over 1 week. This was given to mitigate the destruction caused by the autoimmune hemolytic process. Broad spectrum antibiotics, meropenem for sepsis, procalcitonin was very high, and she also required supportive anti-epileptics for PRES. Next, please. The urine output gradually started improving after the degestant of the right kidney. The creatinine also started improving after degestanting and couple of hemodialysis and plex, and eventually from 13 it came down to 2.2. Platelets started rising to lower normal level to 1.2. Hemoglobins also improved, and the patient had an illogical stability. And in this improved situation, she was finally discharged. Next, please. At 4 weeks, when she came for follow up, her hemoglobin was stable, the platelets were stable, creatinine was still at 2.2. So, that much of renal injury was irreversible, but she was on good conservative therapy. So, during discussion, what we want to tell you is that the patient had severe anemia, refractory thrombocytopenia, and these were multifactorial in origin. There was autoimmune hemolytic anemia, APS related TMA, and sepsis related microangiopathy. We brought in APS because her posterior DRVVT was there, and there was history of infertility, neurological involvement, and thrombocytopenia with arteriovenous thrombosis. PRES was due to endothelial dysfunction, hypertension, and microvascular injury, which occurs in SLE with overlap. The renal dysfunction was multifactorial. There was lupus activity, thrombotic ischemia, bilateral obstruction of uropathy due to calculi. So, in my view, not only dialysis but DJ stenting, removing the hydronephrosis, and treatment of immunological status of SLE turned the tide. Next, please. So, steroids, our first line immunosuppression were given. Plasmapheresis was done to remove the autoantibodies and immune complexes. They helped in TMA neurological involvement. Rituximab was given to target B cell therapy, further refractory thrombocytopenia, and antibiotics were given to control sepsis, which was also driving the disease. So here we had a existence of SLE with APS, press, and obstructive nephropathy. Friends, it is important to recognize the each and every complication and approach the patient in a multidisciplinary approach for better results. Next, please. So this patient had convergence of SLE with APS, press, and obstructive nephropathy. AKI in lupus could be multifactorial. We know it is mostly autoimmune, thrombotic if APS is associated. But as in our case, sometimes mechanical factors could be riding. There may be a clot there. We had stones in our patient. So you need to timely decompress them, give them proper immunosuppression, plasmapheresis for uh, TMA, and biological therapy rituximab. And this heightens the pitfalls of overlap syndromes and dangers of considering that all the ileal failure was due to lupus only. So here multidisciplinary precision-based approach helped us in having a good outcome. Next, please. And that is why I presented this case, because there was simultaneous presence of autoimmunity, thrombosis, neurological insult, mechanical obstruction, non-immune pathology obstruction. Patient recovery came in because we were able to tease out all these factors and treat them effectively. And precision therapies with biologicals, as we gave a rituximab for future avoidance of recrudescence, was absolutely important to better the outcomes. Especially, she had a very refractory hematological lupus. Next, please. Now, few words about lupus. Lupus, you know, is a chronic autoimmune inflammatory disorder which is relapsing and remitting in nature, and it is characterized by abnormal immunological function and production of autoantibodies. So there are three things here. It's an autoimmune disease, relapsing, recurring, and causes presence of antibodies. And lupus nephritis is a severe manifestation of SLE. Friends, it is more common in African Americans, and prevalence is 30 to 60% of SLE patients worldwide will have lupus nephritis, and it is more common in African, Asian, and Hispanics. Next, please. This is the pathogenesis. For short of time, I will only say there are hormonal factors, genetic factors, environmental factors like UV light, and many pathologies have been incremented like increased TS17 pathways, decreased Tregs, release of interferon. BAF is becoming a big player in pathogenesis. April by dendritic cells can promote B cell survival. And there are also roles of netosis coming in, which causes increased netosis, decreased clearance of net, and cause severe nephritis. Next, please. In short, what happens is, friends, that if the apoptosis is impaired, so whenever the cells are dying, if the clearance is impaired, lot of nuclear material is lying in the stream. This is picked up by the macrophage, and they present this to CD4 T cells. CD4 T cells cause excitation of B cells, B lymphocytes, and there is a plethora of formation of circulating immune complexes and antibodies, which causes tissue destruction. So, apoptosis causing impaired clearance of the autoimmune nuclear material is important trigger. Next, please. So to diagnose lupus nephritis, you must have proteinuria of more than 500 milligram, which is threshold for lupus. If it is below 500, we do not biopsy, but 500 and above, biopsy is normally done to classify the severity of lupus, type of lupus, and the treatment and prognosis. Next, please. So when to do kidney biopsy? You can do it anytime, or especially at the time of lupus flare. You know, lupus is waxing waning. So if the disease was quiet and suddenly it becomes very torrid, you must biopsy. Serum creatinine will help you in deciding if GFR is coming down. Simple test, urine routine, if 2 plus micros protein is there, 2 plus or more, or if RBCs are there, more than 5% of RBCs or RBC casts, then a 24-hour urine collection more than 500 milligram, and dsDNA or complement levels, if they are low, dsDNA is positive. These are indications that the patient must get a kidney biopsy. Next, please. This biopsy will help you in diagnosis. A word about HCQS. Why should it be given? It has huge benefits. If you give an HCQS, these are the references. It decreases disease activity, decreases systemic flares, causes decreased mortality, requirement of steroids reduced, thrombosis is reduced, reduces infections, lipids are better controlled, and there are also evidence specific to lupus nephritis in reducing lupus nephritis prevalence, improves response to therapy, decreases flares, and decreases progression to kidney failure. So HCQS is a very, very important drug in lupus nephritis. Next, please. And adjunctive therapies, please do not forget adjunctive therapies like cardiovascular risk factors, lifestyle modification. Please stop smoking, weight reduction, lipid control, blood pressure control. In quest of managing lupus, these common things which will be piggybacking the patient should be managed effectively. Proteinuria, control diet, control blood pressure, and give RAS and SGLT2 to reduce proteinuria. Avoid nephrotoxic drugs like NSAIDs, aminoglycosides, unnecessarily dyes. Contrast to avoid nephrotoxic insult. Infections, especially herpes, tuberculosis, you should assess. Good vaccination should be given for hepatitis B and pneumocystis. Zero-vaccine prophylaxis by cotrimoxazole is preferred, and influenza pneumococcal vaccines and others should be given. Bone is very important because a lot of steroids are given. So you must look at bone mineral density. FRAC score should be seen to look for the fracture risk assessment. And calcium, vitamin D should be given. Osteoporosis should be managed. Ultraviolet should be strongly avoided. We know ultraviolet exposure to sunlight will worsen lupus. Then a young female, if she is desirous of her child, before you give her strong cytotoxic like cyclophosphamide or other drugs, ovarian failure should be prevented by GnRH agonist. Cryopreservation of sperms and oocytes could be done. Cancer individual risk factor, age specific screening should be done. And unplanned pregnancy should be avoided. It should be a planned pregnancy when lupus is in remission. Next, please. So when do we biopsy? After biopsy for treatment, if there is only little bit of proteinuria, then immunosuppressive treatment by steroid or cyclophosphamide is governed by extrarenal involvement, may it be arthritis or neurological or whatever. But if the patient has nephrotic syndrome, then we treat these patients as minimal chain disease and give steroids for remission, and then we gradually taper to low dose steroids. Next, please. For class 3, class 4 lupus, recommendations are that you must give them either mycophenolate or cyclophosphamide. You can give any one of them along with steroids. So give them Celsat with steroids or endoxan with steroids. Now new drugs like belulimab are coming, and calcineurin inhibitors like voclosporin are also coming, which we also use often. But you can give CNI only when the GFR is not very low. It should be above 45. Next, please. And glucocorticoids. So the trick is earlier high dose steroids were given, then moderate dose steroids came, but we tried to give them low dose now. Start with 3 pulses of 250 to 500 milligram, and then come down to 30 milligram per day, and gradually taper them down in 6 months, 4 to 6 months to 2.5 milligram. Earlier we were keeping them at 10 milligram per day, but more the steroids, more the complications, so we should avoid them. Next, please. Voclosporin is another important drug, new drug. You could give only if the GFR is more than 45 and give it cautiously. Avoid if there is sclerosis or fibrosis in the biopsy, and it is effective for nephrotic proteinuria. but flares it does not reduce. Pregnancy it is not recommended. Next, please. IV cyclophosphamide is given if the disease is very severe and who cannot take oral drugs. So there we give high dose cyclophosphamide up to 1 gram monthly for 6 months. Urolupus is a very popular regime. Here we give 500 milligram every fortnight for 3 months. So 6 injections of cyclophosphamide, or patient can also go for oral cyclophosphamide. But then compliance is an issue. Next, please. So triple immunosuppression with the advent of belulimab and steroids is very popular with mycophenolate. But you can also use azathioprine or leflunomide in combination with steroids, especially if these drugs are not available or they are expensive, patient cannot afford them. You can use azathioprine. Next, please. So when we are using new combination like belulimab, this is not available in India, but it will soon be available. We can use it when CKD is not very severe, GFR is more than 30, histology is not very bad, and it will decrease all flares. It is effective in MMF. Its effective combination with cyclophosphamide so far is not known, but you will have to give it either IV or subcut, and it has significant long-term record of efficacy in extrarenal lupus also, but in pregnancy it is not recommended as an add-on therapy, did not increase the risk of adverse effects, so fairly safe. Next, please. Other options like Rituximab, ocrelizumab, co-stimulatory factors, anti-IL-6, and antibodies against type 1 interferon receptor unit, anifrolumab, are very exciting new therapies. But at this forum, we cannot go any further. Next, please. Maintenance therapy, I'll skip. Suffice to say that you should try to keep them on small doses of prednisolone. Either give them pred mycophenolate or give them pred azathioprine or tacrolimus prednisolone. So you can give any one of them. After achieving remission, you have to give maintenance, and you can choose any three: mycophenolate, azathioprine, or tacrolimus with small doses of prednisolone. Next, please. And in class 5 lupus, which is like membranous nephropathy, we treat them. If there is low level proteinuria, just give them RAS and ARB and HCQS. If the proteinuria is very severe, then we give them combination of steroids and mycophenolate or cyclophosphamide. Next, please. All of them should get HCQS. So ULR recommendations are initially HCQS, glucocorticoids, and mycophenolate. Then low dose mycophenolate and azathioprine with steroids. And maintenance, as I said, mycophenolate with CNI or mycophenolate with azathioprine, replacing mycophenolate. Any of the above can be used unless it is contraindicated. You should give at least for 3 months, and gradually at 6 months, dose should be reduced to more than 50% as the proteinuria comes down. And at 2 years, if the proteinuria is less than 0.5, you could start taper. Next, please. And these are the KDIGO recommendations, class 3, 4. Assess activity and chronicity. Treat them with steroids, zero point 0.2 to zero point 0.5, which comes to about 20 to 30 milligram for a 60 kilo man. First, you give them IV prednisolone, and then you give oral steroids. You can give them in combination with mycophenolate or cyclophosphamide or belulimab with mycophenolate is that one of the newer modalities. Next, please. And so the paradigm change is coming in lupus management. Belulimab is coming in a big way. It is intermittent subcut therapy. Glucocorticoids still remain the form first of therapy, and you can use either cyclophosphamide or MMF. Other regimes are also there like voclosporin, steroids, and MMF. Next, please. This is enough for physicians and other practitioners. How do you see the response? Proteinuria should start coming down. It should be less than 0.7 grams. Then partial response if the remission is more than 50% but less than 3 grams per day proteinuria. In complete response, the proteinuria should be less than 300 milligram per day. and it should stabilize the renal function. GFR should be stabilized, it should not worsen. And within to 6 to 12 months of treatment, no use of rescue, and the patient remains stable on low dose. If these do not act, then the patient is resistant to treatment. Next, please. So, when is the treatment unsatisfactory? If the adherence is not there, adequate dosing of immunosuppressed medications should be seen by plasma drug level measurement so we know that the patient is compliant. Sometimes you may need to repeat the biopsy if there are concerned that the disease is already advanced and the kidney is chronic and there is no point in further giving strong immunosuppression. And you can sometimes also change to other medications if the patient still has disease. Addition of Ritax, extended course of IV cyclophosphamide, and other newer drug trial drugs could also be considered at appropriate forums. Next. If there is a relapse, you have to treat it just like the first time you treated it. But if you are feeling that it may not work this time, then you can use the alternate therapy. Next, please. In pregnancy, you have to be very careful, counsel them to avoid pregnancy if the disease is active. This is very important. And only after 6 months of the lupus become inactive, a patient should be allowed to become pregnant. Risk of pregnancy to reduce it as sequence should be given all along pregnancy along with low dose aspirin to start at 16 weeks. Steroids, hydroxychloroquine, Azatac, and cyclosporine are safe, but mycophenolate is contraindicated. Next. In children, same like adults, but please take special consideration of the doses, their growth velocity, fertility, and psychological factors, which are very important in children. Next, please. I think I will stop here for want of time, and I thank IJCP and Ankana for having me here. It's a fairly big topic, and we need to stop. Thank you. Thanks a lot. Ankana, you can take it from there.
Thank you so much, sir, for this major deliberation, and you have prepared us so beautiful the PPT was. Sir, we won't take much time, but we have received a few questions. Can I just take two questions from there?
Yeah. Okay. Okay.
So the first question is how do clotting and inflammation synergistically worsen renal damage in APS with lupus nephritis?
Say that again. There's still a lot of echoing in your. Yeah. Please repeat the question.
The question is how do clotting and inflammation synergistically worsen the renal damage in APS with lupus nephritis?
Yeah. So what happens is that APS is the black swan of the disease. There are antibodies against phospholipid which form the important constituents of the membrane. And when this membrane is damaged, these receptors are exposed and they increase platelet aggregation, and the other clotting factors are also brought in by intrinsic pathway, and the clots are found in the vessels, and these clots cause ischemic insult to the organs downside, and they can also employ elsewhere. So on one side you have thrombosis, and because of thrombosis and because of consumption of these factors, they may also have a possibility to bleed, especially if the lupus is active. So it goes both ways. But most of the problem in APS is due to thrombosis, due to unchecked thrombosis of the microvascular system and slightly bigger, smaller vessels.
Okay. Next question we have received. What is the contribution of complement activation in this overlap syndrome?
Yeah, the complement activation occurs by classical pathway, and C3, C4 consumption is occurred, and that inflames the inflammation in lupus. And along with that, if the APS is also piggybacking lupus, then antiphospholipid antibodies are bringing thrombosis. So on one side there is inflammation, other side there is thrombosis, and there is lot of vascular damage to the organs.
Okay. Thank you so much, sir, for your expert
Thank you.
opinion that you have shared. And I'd also like to thank all the participating doctors for your continuous participation at our platform. Thank you once again, sir, for your valuable
Thank
time
you.
and for being with us at our platform.
Thank you.
We hope to
Thank
see you
you for
again at our
having
platform.
me. Thank you.
Thank you, sir. With all your permission, we are just ending the live here.
Okay.